I'll help. Don't worry.
All right. Well, should we get started?
Sure. Keelan, are you good?
Yep, I'm good.
Okay,
So
perfect.
good evening. I'm Kim Burkhart. I'm a clinical psychologist at Rainbow Babies and Children's. It's my pleasure to introduce our speakers for tonight's forum, Doctors Quinn and Merkle. The purpose of our virtual consultation session is to build upon OPA's efforts to respond to the ongoing discussion many association members have had, as we've all had to develop competencies in telepsychology. This session will emphasize telepsychology practice issues across child and adolescent populations. We will not be discussing issues related to billing and insurance in this particular group supervision. This is also not a forum to discuss the content of your telehealth sessions, so it's purely to help with the practical applications of telehealth. We also encourage that you do chat, and I will be sending messages along the way so we can have a lively discussion. To introduce our speakers, Dr. Quinn holds an APA accredited doctorate in urban education, counseling psychology from Cleveland State University. She's a clinical psychologist in private practice near Cleveland. She provides counseling and assessment services to children, adolescents, and young adults, and works very closely with parents. Some of her areas of specialty include ADHD, oppositional defiant disorder, and executive functioning deficits. She was recently appointed co-chair of the Communications and Technology Committee, and she's the editor of the Ohio Psychologist through OPA. Dr. Merkle is presently the central office school psychologist for the Akron Public Schools, where he oversees the pupil adjustment program between the Departments of Student Support Services and Office of Special Education. He's concentrated his work on consultation, evaluation, and intervention for students with severe social, emotional, and behavioral needs. He has his doctorate in school psychology and psychology, and he serves as the president of OPA.
Perfect.
So without further ado.
Thank you so much, Kim. So for our participants, welcome and thank you so much. I appreciate all of you being here, especially it is the NFL draft, and I know that's probably just a preeminent concern among many of our participants, but it is the start of the NFL draft. So we will certainly try to be timely and to hasten our time by 9 o'clock so that if that's an interest to you to catch some more. We will be using the chat feature, and if you are on one of the Zoom apps, especially a laptop of some sort, if you wiggle your mouse or your trackpad, you should see an option to open up a chat window. And the chat window, once you do that, you can post questions. That will help Keelan and me be able to try to respond the best we can. If you are on a voice call, unfortunately, there is not a way to do chat. If you have the ability to join us through an app or online with your desktop or laptop, that would be great. If not, certainly don't feel cheated by the experience. You just want to get the full experience of Keelan and me and our interpretive dance and our beautiful faces such that they are. So maybe at this point then, if everyone can be mindful to set yourself to mute, just so we don't have ambient noises. If you are on the app, you can simply click the little microphone in the lower left-hand corner, or do Command or Shift A, which will turn off your audio. If by some chance you're on video and you need to turn off your video, like your cat jumps on your keyboard or something like that, you can hit Control or Command V, and that will turn off your video feed as well. And at this point, does anyone have a question on just using the general interface here before we get started? Okay. Well, Keelan, may I give you the proverbial tag and invite you into the conversation?
Yeah, so I'm excited to be here, and it's my first Zoom big call. So I am here to speak. I've been working with kids and adolescents for probably almost, 10 years now. A lot of agencies, I've been in private practice for about 3 years, but like a lot of other people, I've just jumped to telehealth. So I've transitioned there. I'm doing at full time, probably 50 to 20 people on telehealth. So I feel for about a month now. So I feel like I'm comfortable with that experience, kind of speaking with it, kids, adolescents, and parents. And then I'm still seeing a couple people in person who are not appropriate for telehealth. And we can talk about what makes an appropriate person or client for telehealth, what's not. But that's kind of what I've been doing so far. It's definitely helping with my flexibility skills and kind of, patience for sure. So that's what I'm hoping to talk about tonight.
Great. And on my side, I'm a child clinical psych who's also a school psych. And probably like many of us on this call, I've had to support across the state a lot of practitioners to gain some very quick skills with respect to teleassessment and telepsychology, especially as we are still waiting in school psychology to hear whether or not federal waivers will come forth, if there's still an expectation to continue forth with evaluations for special education, Section 504. And then how do we proceed? So I will certainly do my best to give you guidance from the major test publishers to major measures, and also just give you hopefully a few pointers on how to access some of the various virtual or tele assessment devices moving forward. So the chat window is open, and please, as you have questions, feel welcome to post those, and Kim will help us as our dutiful moderator to field those questions and put those out there. Keelan, if I can look at you as we look at our Birdie Brunch screen here of all of our faces, maybe help us know a little bit about how did you kind of make the transition to telepsychology, telepractice, and what does our team need to know, maybe if they're contemplating the same?
Mm-hmm. Yeah, so I've always kind of wanted to do some telehealth and telepsychology, but it wasn't covered by insurance at the time. And then when COVID hit the US, we were just we knew it was going to happen. Or even if it wasn't covered by insurance, we knew we had to have this option, because a lot of my parents, the kids' parents that I work with, a lot of them work in the hospitals, and they were coming saying, we're not going to be able to come in all the time. So we were just kind of problem solving. So as a practice, we started looking for options, HIPAA compliant options, and also kind of, there's 13 of us, were all independently contracted, so we couldn't do a big service. So we were looking at free services with telehealth, and we chose Doxy.me. So, and I tried a couple out, and I'm kind of the head kind of tech person at work, just kind of sad, but we did that and we started it. And how I transitioned is I have a couple clients I've been seeing for at least a year. So who were kind of lower level, lower risk. So that was kind of the first start. I started with a couple of clients who I felt like I had a good understanding of, a good relationship with, who were not had any safety risks or anything. So I started with that person for the week. The next week it increased. And then by the end of the second week, we were in quarantine. So that's kind of how I transitioned. And I'm glad we started early and kind of just increased from there.
And Keelan, I don't know if you want me to pipe in on this, but maybe reminding our participants tonight of some of the various HIPAA compliant options they might have available to them for telepractice.
Mm-hmm. I know of a couple. I could not remember. Zoom has a HIPAA compliant option. You have to pay for it. It's not the basic level. A lot of people think it's the basic level. It is not. I think it's 2 steps up. It's not the middle one. It's the highest level, when you have to pay per user. So the price increases. I know, Erich, you mentioned Google Suite, I believe that does, or G Suite, the business account for Google has a HIPAA compliant option. Technically, I believe FaceTime is HIPAA compliant, or not HIPAA compliant. They can offer a BAA, but I don't choose to do that. I want to be through an actual system. And I know there's another option that's free. I cannot remember the name of it though right now.
And Keelan, so just so our team maybe has the terminology. BAA is not like bah, like what
Ah.
Sugar Lamb say. It's a business agreement. And so Google Hangouts can be HIPAA compliant, but you do have to go into the next tier, and there is also a per use charge to it. And then if you enter into that business agreement, the BAA with Google, then it becomes a HIPAA, and if you're involved with psychoeducational assessment, also FERPA compliant. A lot of school districts are using Google as their ecosystem, so it's not unfamiliar, and most of the school systems should be also at least HIPAA compliant on the Google side of things. The Zoom side of things, remember, if you go into Zoom for healthcare, then that becomes a HIPAA compliant option, but it is a significant additional cost. And then Keelan, as we were having some camera dysfunction, you mentioned Doxy. Do you want to maybe just mention Doxy if folks aren't familiar? DOXY, I posted that, doxy.me, on the group chat too.
Awesome. And there is a blog post on the new CTC committee website. Not sure what the website is yet. I think they just put it out today. But
The Communications Technology Committee, for people that are not speaking OPA on the call.
Say what'd you say?
I said that's the Communication Technologies Committee, in case you don't speak OPA.
Yeah, sorry. So Doxy.me, it's a platform and there are different levels. All 3 levels, there's a free version, there's a clinic version, and then there's, it's a practitioner where you can do multiple users, and then a clinic, which is for a larger span. And they are all HIPAA compliant. They all offer business associate agreements that are really easy to edit. And I mean, each step up has more options, but the free option, what we use, it has the camera, it has the audio. I know some of the upper ones that you can screen share, which is nice. I'm looking into that, but for basic level, for basic introduction, like when we needed to get it immediately, that was a good option. There are some connectivity issues, but I find that I get the most issues when they're on a cell phone and also when they're moving around. Like sometimes the kid has me on a phone and then they're, oh, I'm gonna go outside now, and then I drop. So, and because I'm in one place, I assume it's them, but I don't know, that could just be me. I can see their connection, how strong their connection is, usually based on what, if they're using a phone, if they're using a laptop, it tells me that. So I like seeing that, and then we kind of problem solve. But I find if I'm on hold, it helps.
That's a really important point. So as we think of the broad umbrella here, whether it's teletherapy or teleassessment, it's the idea of really kind of carefully triaging your clients or patients to see if they have the internet connectivity to actually be able to do this work. And whether it's teletherapy or, as we get into in a few minutes, teleassessment, there needs to be a robust, solid connection. And especially a lot of our kids are using, at best, probably Wi-Fi connected to their smart device. So it is important that as you start thinking of your clients or patients who could access these types of services, do they actually have the robust infrastructure? And not everyone simply does have that infrastructure to do it. Likewise, if they have the home connectivity to do it, that's one issue. Generally speaking, you probably want to make sure your clients or patients have an internet connection of at least maybe 5 to 10 megabits, and preferably closer to 20 megabits, especially given all the various things we have in the Internet of Things. If it is an issue of that they are not connected to Wi-Fi or internet, we want to be very sensitive to our clients and patients too, that there is a lot of data load on this. And if they do not have unlimited data, this can start to get very expensive very, very quickly to start push all the various quantities of video.
Yeah.
So, Keelan, I saw as Kim is helping corral some of the questions here, a little bit about assessment. So what do you think, Keelan? Is it okay if I launch into a few points about assessment?
Definitely. Feel free.
Okay, perfect. Before we leave, just a broad stroke of the technology. Does anybody have any questions about the technology options between Google, Zoom, Doxy? Remembering to make sure your clients or patients have the internet access one way or the other, whether it's through their provider or if it's through their smart device and it's cellular data. Are we okay if we leave that? Okay, so let's talk a little bit about assessment. The broad option I'm going to offer you, just as I'm really trying to support school psychology practices, just because you can doesn't mean you should. Remember, when we looked at the normative and the standardization factors of most of our measures, they have not been normed or standardized on a virtual assessment platform. Now, there's been some very fast and furious activities. So Riverside, for example, has now done a separate standardization project to try to get their Woodcock-Johnson measures, for example, to be valid with some exceptions, and I'll come back to that in a second. But Pearson, for the Wechsler scales or the KTEA, is now saying that you certainly can do some tele-assessment work, but they may or may not be entirely as valid or have the fidelity to the measure. So I want everyone to be very cautious to the fact that the individual assessment of either cognitive skills, academic skills, or maybe neuropsychological assessment, there are some adaptations available, but just remember the vast majority of all of the measures are not right now standardized in a way that probably would permit us to have a completely valid and reliable approach. That being said, there are a number of considerations being put forth by each of the publishers. So stepping back for a second, and when Keelan and I were kind of talking about this session, one of the best ways that we can do some tele-assessment is going to be through the behavior rating scales and the various types of measures that we would use, either through MHS, which would be measures like your Conners scales, your ASRS, your Justness scales. When I say Conners, I'm saying Conners Comprehensive, as well as your Conners very specific for ADHD, the anger regulation scales, and so forth. Those do really well to give and distribute to various actors when it comes to the online. When it comes to adaptive, WPS, Western Psychological Services, also the same thing. You can do online measurement very well with those. Now, there's a couple gotchas there. So first of all, I'm going to say, if you've not gotten into the place in your practice where you have an MHS or WPS online account, it's something, if your practice can sustain it, that is far more worthwhile. All of us can appreciate the days when we've had, file drawers full of the various permutations of the BASCs and the Conners. The online version is really fantastic for all of those measures, because instead of having to have file drawers of all these various protocols for different age ranges, you simply need the online access. Now, depending on your situation, it may or may not be cost prohibitive. If it's not cost prohibitive, I certainly recommend it. And you certainly, I will put my my email up here, and I can help link you to some of our test representatives for WPS and MHS if you have interest. Drop me an email and I'll make some connections for you. The online approach is so much nicer because now you no longer have to have all those various protocols. You simply can access them online, print out, or you can email the protocols, which can be completed online, which is really wonderful. In addition to that, then the protocols can be scored and interpreted through the online interface, which, as we all appreciate, if you're doing a sizable number of evaluations, having the scoring and interpretation can certainly shave off a lot of time. So understand, at least when it comes to the Connor scales, the BASC, which we'll get into the global world of Pearson in a moment, that's a separate discussion, or WPS when it comes to some of the adaptives. Really wonderful. But again, it's really going to be based on a cost factor if that's appropriate for your situation. From there then, the next part is to think about some of the logistics of the assessment. We know that behaviors are going to be wildly different in the home environment, and are you measuring the same constellation of behaviors, especially if you're asking parents who maybe have seen their kids just for a certain fragment of their day versus maybe, 18, 20 hours of their day. Does the measure still hold up? So again, think about that when it comes to the behavior assessment of all of those various rating scales. They really do work very well online. I would say, again, if you can do it, it is much nicer than having all of those protocols just sitting around that you need to complete. But again, it's going to be a cost factor for your situation. When it comes to now some of the Goliath measures, Pearson and their Q global system. And I don't know how many people here are using Q Global. Can we do a show of hands if you're using Q Global? Okay, so we got some hands there. Q Global works very well for a number of different purposes. Now, within that, you can now do some of the teleassessment work. The KTA and the Wechsler scales are certainly set up as such. Now, the expectation is on the other side, there's going to be a helper to try to do some of that. Now, what helper means could vary in your situation. It also means that, again, that the family has a robust enough internet connection to make that work. It also means that the testing environment is going to be free from sources of contamination or error such that you can actually give those measures. But Q Global does allow for the teleassessment. Now, keep in mind the Wechsler scales were never normed or standardized in any way for teleassessment. So the gotcha here, or the asterisk here, is that if you're going to go down that road, you do have to caution in your interpretation that this was given through teleassessment. Now, you'll have to use your own clinical intuition and skills to decide whether or not that's going to be a significant fault to the validity and to the reliability of the assessment. But you can do it. Now, when it comes to the Woodcock-Johnson series, Riverside has partnered with a company. And I'm just going to screen share for a second to show you this. I hope. We'll see what happens. Screen sharing is always a wild card. But I want to show you this guidance document from Riverside, and this is Riverside Insights. So when it comes to the Woodcock-Johnson measures, there are a number of the subtests that are designed to be able to just require verbal responses. And so those will work very well in a teleassessment. But again, the asterisk here is, remember, these measures were not normed in a virtual or teleassessment practice format. Now there is, as you might imagine, Riverside is calling it the premium solution, which for us means in the real world, more money. And the premium solution is they partnered with a company called Presence Learning, which now has a complete online adaptation of the Woodcock-Johnson measures so that you could actually give them. Now there is a per use agreement here. I put this on the webpage. You simply could, but so that you don't have to remember this, you have two options. You can either talk to your Riverside rep if you have one. If not, drop me an email and I'll get you a Riverside connection. Or you can just Google Riverside and online assessment. And if you do that, you'll see on the screen that I put here, this Presence Learning. This actually is an adapted version of the Woodcock-Johnson measures for virtual assessment. And this now at least has been normatively updated to try to be as close to it can to a robust, valid, and quality online measure. So broad picture, Pearson measures are not adapted in any possible way for online measures. However, there are processes that you can use. Again, if you drop me an email, I can send you some of the guidance documents, or you can just simply Google Pearson and virtual assessment. They have some really great guidance documents out. But your gotcha there is you really do need to asterisk that in your interpretation. They may or may not have all of the psychometric properties consistent with a traditional administration. Riverside, the Woodcock-Johnson measures in particular, there is an option where you can actually use that presence learning to do a full online administration, but there's going to be an extra cost factor. There is sort of the in between when it comes to Riverside, where a number of the subtests that require visual stimuli or sound information are actually available, and they've been made into a digital format. But again, your asterisk there is you're still going to have to caution your measures and interpretation, whether or not you suffer any kind of validity or reliability. In those cases, again, you're going to want to kind of carefully consider your clients and patients. Is this the type of assessment for which that's going to be appropriate or it's not? So again, online measures, rating scales, probably your best option when it comes to like MHS or WPS. Riverside has a full online option. They have a hybrid option where some of these have been adopted. And then Pearson has tools available, but again, may or may not have the psychometric characteristics for your given assessment situation. So I feel like that was a lot of talking all at once. So let me pause there and stop talking for a minute, and let me check in with our team here.
I will say I did check in with that representative from Pearson today, Erich, and I did not know telehealth teletesting was even an option. And I was glad you need a screen share to do the WISC, and the Wyatt was up there too, which are the things that my practice does. So I did not know there was an option. I was really, because we just stopped all of our testing and I'm just finishing cases. But now that I know it is an option to at least start or do partial until we can get back in person, like I was really happy to see that through Pearson. But again, with that caveat, it's not norm to that, so.
Yeah, so again, the caveat is on the Pearson measures, definitely not normed. Riverside measures, if you go to the extra step, the presence learning, it is at least had a normative study. Otherwise, you know, there is adaptation. But again, depending on the purpose of your assessment. So like if this were really a significant forensic assessment, I'd be very cautious stepping into this. Or if it was a controversial psychoeducational assessment, I'd equally be cautious. Remember right now, the U.S. Department of Education guidance, as well as the Ohio Department of Education guidance, is that any face-to-face assessments should be forestalled until schools resume such that that can happen. So do keep that in mind, and that would also be true of the forensic context. But I'm glad, Keelan, you were able to connect with Chris McMorris, who's a wonderful, wonderful person. And if there's anybody who could help your practice, it's certainly Chris, and I can certainly help any of our team here connect to Chris and the Pearson Goliath if you need that.
Yeah, it was a great conversation. It was like over an hour long. I was like, oh, I could talk about testing all day, so. And I see the question about secure email. I only have experience through Pearson, but when I send like BASCs through Pearson, like for people to complete remotely, it is sent through the Pearson website, and it doesn't go through email whatsoever. It's sent to them through Pearson Q Global, and then it's returned through that. So it doesn't even, it's secure. It doesn't even go through emails. I'm not sure about MHS though.
Yeah, so MHS and WPS is going to send us sort of a generic email. And then for your practice situation, if it fulfills the HIPAA compliancy requirements, you know, that's something you're going to have to look at. I would say more than likely, probably not, because again, if I put in, you know, foo@yahoo.com, it's going to send a protocol to foo@yahoo.com. And so that certainly is not going to satisfy the HIPAA expectations in that kind of context. In addition to that, remember again the asterisks, whether or not the rating scales, if they are completed in that circumstance, if they are actually going to be reliable and valid for your purposes, given all the nuances of our situation. I did also see that there was a question here about assistants present in the room. So Pearson has adapted their measures, but there is still the expectation that someone could help. Now, in older students, that's older children and adolescents, maybe not so much, but certainly for younger children, very much so. I would say just on clinical experience in the last couple of weeks, young childhood assessment probably is not the best format unless there is just a significant need to get an evaluation done, because that is very much going to require a parent or guardian to be in the room to navigate the screen, the tablet, whatever it is. And then you're going to continue to introduce the various sources of error there based on that. The older children, you can do the screen share, or you can also do even sharing the connectivity with an iPad or a tablet. May not need to have the person, but that's going to be the gotcha when it comes to the more traditional standardized one-on-one assessments, is that you're going to need at least a grown-up somewhere in the vicinity to help with the technology issues. And again, we all know when we do child and adolescent assessment, we typically do not want to have a lot of our grown-ups around for test security and performance factors and all those things. For young children, it's an inevitable part. You're going to have a grown-up around. So I would significantly say, really look at the case-by-case situation. If you can forestall the assessment for young children, very much so. For older children, I think you have to really look at, again, the factors of whether or not the family has the technology infrastructure, and then is this a family for whom you can kind of dispatch some of those tasks or not.
And there was a recommendation of you are seeing the client through screen share, and then it was also recommended that there is a second FaceTime on a different document looking at the whole environment. So you can from a different angle. So you can see, you're seeing the client face to face, and then you also have a separate video on from a different angle, just so that you could see all the areas. So yeah.
And Keelan, I see a question I wonder if maybe you could talk about, which is non-psychometric assessment, family history, psychosocial factors, family roles, who's supervising online teaching, what's being offered. So maybe if you want to talk about some of the non-psychometric assessment, and then I'll come back around to some of the educational components there.
Yeah. So as of right now, I've not done intakes or new client sessions online. That's going to change as of next week, but I plan to do it kind of the same way, except through telehealth. I'm getting all the history, I'm getting all the data, but especially through my therapy services. I work with a lot of kids and adolescents. With young kids, it's just like my therapy. I start with them together, and then the parent gives me an update. The parent leaves, I'm with the kid, and then either parent comes back in and we summarize, or we do a switch. So it's always kind of a combination where I'm getting information from multiple people from different angles, just to see if it's, even and the same thing is being reported and things like that. School has been really kind of tough because every school is different. I feel like the younger the kid is, the less schooling that there is, and that leaves so much to the parents. They're really expecting parents to be teachers for some of these kids, and it's really tough for them, and it's tough for the kids to be learning from their parents. Depending on the school, some of my teens, they have to be clocked in at 9 a.m. So my middle schoolers, they have to be online from 9 to 3 with some breaks in there. A lot of times it's just they have to schedule meetings throughout the day. I would say my younger kids, it's just 9 to 11 or 9 to 12, and then they're done. So that's kind of their schooling. And then they're kind of free to roam, which is really hard because they have older siblings that are expected to be at school and still doing homework. They have parents in the household doing their work and they can't be there. So it's been really tough. So what I do is I'm very behavioral and I do a lot of scheduling and I do a lot of charts and a lot of token systems and incentives and things like that. I've just been setting up a lot of my younger kids with just daily kind of routine lists, like starting from the morning, here's your school hours. Every child usually has like an hour of outside time, of creativity time, of quiet, independent, non-electronic time, just to kind of do some problem solving skills and how to fill their own time. So we try to fill the schedule to fill like their entire school day. At least when they are on that system, then the parents can refer to, look at your chart, like what did you earn today? How much electronic time? And then they get the electronic time during the electronic hour. It's hard to stick with that, but I think it also gives the kids the structure, something to go on to at least keep them going throughout the day. Sometimes it works, sometimes it doesn't. It just depends on the household.
And I think building on that, Keelan, it's really important for our parents to understand that your kids may be in school for 6 to 8 hours a day. The expectation for online instruction is that your kid is not sort of going to be duct taped to a chair for 6 to 8 hours a day. And developmentally, by and large, what we're asking from the school prerogative is between 1 and maybe 4 hours a day, depending on if we're talking about early elementary to high school. So again, 1 to maybe 4 hours is kind of your range. For most kids, it's probably 1 to 2.5-ish hours at most. So every school district is approaching this a little different. Appreciate that some school districts like mine, where I work in Akron, every student had a Chromebook. We already had a pretty good, robust digital learning platform in place. Some school districts, students didn't have access to Chromebooks or tablets or anything. In addition, there's a lot of inequalities when it comes to internet access, depending where you're at in the state. So many of our students and many of our school districts simply are just trying to build the plane and fly it at the same time, so to speak. So again, though, the instructional effort or the amount of concentrated effort really should just be a fractional part of the overall school day. And it's certainly by no stretch is anticipated that it's going to be the 6 to 8 hour typical instructional day. Also, the teachers are all over the place when it comes to, some teachers are saying that you need to be online at 9 o'clock for this class and 10 o'clock for this class. Others are saying, well, I'm going to have this block of office hours. Here's the assignments that I need you to complete, and you can talk to me then, and then that's it. And then there's other places where they're saying things like, I'm available all day long. We're going to have structured lessons. Oh, and then at 8 o'clock tonight, I'm also going to read you a bedtime story. So it really depends on each individual school district, what they're truly doing. I will say the vast majority of teachers are really working just incredibly, incredibly hard, and probably, much more arduously than they've ever worked in their traditional instructional efforts. And the biggest issue I'm seeing on the sort of administrative side of things is teachers being able to turn it off and say, okay, I've given my work day. I don't need to keep doing this because I keep responding to emails and getting into conversations and things of the sort. And then related to that issue too is the ever important need to be mindful about child maltreatment, abuse, neglect issues, as well as at the same, because we know child maltreatment and domestic violence, unfortunately, is on a rise. And then equally so, being very, very conscientious to the fact that there's an increased level of suicidality and even some threat assessment, and sort of diverging from that, even cyberbullying and bullying related behaviors. Some of my students with emotional disturbance in my district, for example, have learned very quickly how to take their emotional disturbance skills into the cyber arena, and they've learned very nicely how to start perpetrating against their peers in the various Google classrooms, for example. So we want to be very mindful of some of those broader risk types of issues. And I see we have a lot of questions going through, Keelan, and my inability to talk and walk and chew gum at the same time. I'm going to scroll through very quickly here to take a look and see what I'm missing here. Kim offered the question that she was consolidating, Keelan, about how you're obtaining information on family history and roles.
Mm-hmm.
Did
So
we?
is that like new clients, or just like typical roles in the household now that everybody's home?
And if someone asked that question, feel free to unmute yourself and help us get some clarity there.
This is Elizabeth. I'm thinking mainly the new, but for sometimes you're working, sometimes you start with a child or family, and due to their schedules or whatever, you don't see them over a period of time. So they're not really new, but you haven't really done a stepwise and really thorough family history, family educational history, substance abuse in the family, all of those things, many of which are a bit sensitive. Mm-hmm. So new, semi-new, any of those.
Mm-hmm. Yeah, and I work with a lot of parents. So I have also been doing parent-only sessions with a lot of my parents on how to build structure to get more information about what's going on too. And that does go through insurance. So if I needed more additional information, I would not hesitate to schedule one of those sessions to get more of that information. And I mean, these kids, they're getting more face time with their family than they have since they were younger, and it's really hard adjusting for everybody. So I go into a lot of I know you're not talking about those types of roles, but everybody's home. So everybody needs to be taking turns taking care of the home and taking care of the family living areas instead of just the bedrooms and things like that. And now, there's time. If kids are only in school for 2 to 4 hours, they have plenty of time to add some things to fill their time. So that I'm trying to build a lot of structure that incorporates a lot of that piece to kind of keep it, because kids work best with structure. That's exactly what school is. So I try to take what they're missing from school and add it into their daily schedule. That includes their social time. Sometimes they have lunch online with other people. That includes the activity. You never realize how many steps they're taking in the school. Recess, even if they're teens, they could spend time outside. It's time, we need to be building things into their schedule. And then I see a question about suicide assessment. So that's also something, looking at who's appropriate and who's not appropriate. With my caseload right now, I am seeing in person the people who are too young to be on telehealth. A lot of kids who I have on the spectrum, I'm seeing in person if they're parents and they're okay with that, and also high suicidality. I have some people who I've been seeing for a while who do a lot of health, self-harm, not suicidal anymore, but it does come back at certain times during certain times of the year. And I feel I have good enough rapport to really kind of know their tells. So I'm comfortable doing that through telehealth. And every time I do check, and I'm checking on it, and sometimes I'm all up in the camera. Wait, why did you look over? Hold on. What do you mean? Why did you say no? And then you totally looked away. So I call them out on a lot of those gestures. With new clients, I would not feel comfortable if there is any history of suicide or suicidality or current suicidality to be seeing them through telehealth only. I would insist on seeing them probably in person, just because I don't have that history, I don't have that rapport, and I don't know them as a person.
And I posted a couple of links on the chat. So For all of our child and adolescent focused folks here, even if you are not connected to school psychology by specialty or training or interest, the National Association of School Psychologists is a wonderful resource. And so there are a number of different very targeted resources from NASP and NASP. And if you're not able to see the chat, just Google National Association of School Psychologists and COVID-19. It will take you to a broad section. So there are some very specific guidance documents related to virtual risk assessment across child maltreatment, suicide, and threat assessment. I will also say that just as a free takeaway, if you're not a member of NASP, there are tremendously valuable resources because, again, these are the folks that are doing so much of the child and adolescent assessment. So even though I kind of walk on two sides of the fence between child clinical and school psych, I rely on NASP for a lot of different guidance documents, and I certainly would invite you to take a look. They have just a fantastic coronavirus pandemic COVID section. So National Association of School Psychologists, just Google it if you can't see the links that I posted. School districts are being charged with being very mindful of virtual risk assessment activities across the three broad areas of child maltreatment, suicide, and threat assessment. The Ohio Department of Education has put forth guidance. Now, the challenge with this is, so like in Akron schools where I work, I was able to lead a task force towards that end and come up with guidance documents for the whole district when it came to risk assessment, as well as crisis types of issues, including deaths and things like that. Your mileage is going to vary tremendously, and not every school district has a robust crisis response. It's hard to say whether or not school counselors or school psychologists are actively engaging in some of that work. I will tell you, a lot of school psychologists are so just overwhelmed right now with all the procedural and technical issues, trying to keep their caseloads compliant in a time where there's no way to keep them compliant. And they're getting a lot of pressure from their administrators and other actors to try to get these evaluations caught up. So school psychologists are in a certain precarious situation. School counselors are, again, across the continuum. Some are doing just magnificent work. They're doing weekly check-ins. They're having sessions with their various class or grade cohorts. Others are not, unfortunately, doing as much. There are state social emotional learning standards, and those should be imbued with curriculum. But again, right now, when we look at the broad picture of education and knowing that so many districts right now are all over the place when it comes to whether or not they're even deploying curriculum, let alone social emotional curriculum, those, you know, for some districts, social emotional curriculum would really be a cherry on the cake when they can't even get reading, writing, and math out there as a effective curricular option. So, but again, take a look at some of those options, and especially in your roles, if you have the privilege or the opportunity to do some consultation with schools. Many school districts would appreciate that, but, you know, of course, check in with what school districts have going on. Like I said, in Akron, I'm fortunate, this may be because of my leadership work, I can have great connectivity to this, but I know my colleagues across the state don't have as much privilege or benefit to do so. And I'm looking again at questions. If someone is suicidal, how are hospitalizations being addressed? So I will tell you, in Akron Metro, behavioral health is largely shut down for crisis situations. Akron Children's Hospital and the Psychiatric Intake Response Center is our regional referral source. They are still marginally open, but most emergency departments, their priority right now is COVID-related symptomology, as well as just the general insult of normal medical emergencies. So behavioral mental health needs are not, unfortunately, getting the priority. So that is a real challenge. I don't know, Keelan, if you have some different prerogative, but we are struggling if students need to have psychiatric assessment or possible consideration for pink slipping or inpatient. We're not having a lot of success.
Mhm. I'm unsure about active suicidality. Like I said, I work with parents, and if one of my clients, even with a history of self-harm or history of suicidal, I'm talking to them more so with telehealth. So even if nothing's being reported, I usually connect with the parents at least every couple sessions. Like, are things still, safety is still, like, is safety still a concern, even if they're denying it? So I just want to make sure. I know that the IOP PHP program that we work closely with is still happening. It's through telehealth though, but they are taking new clients. I've referred somebody there already. They are doing, and it seems to be working, but again, it depends on the case. It depends on the situation, but I know IOPs are happening telehealth.
And we're also finding, Keelan, too, even like to have police do wellness checks is becoming increasingly precarious. The police, at least in the Akron metro area, are telling us that, they're practicing social distancing and they're disinclined to want to do that. And EMS is telling us that they're responding disproportionately to too many other acute crisis needs related to medical issues on COVID. So we're finding it very difficult to get dispatching to even the high tier suicidality, homicidality kind of concerns.
Mm-hmm. And it's related, but not, thinking about mandated reporting. I mean, in the first week I had to call child services twice, and they seemed to be like running. They were at the house within 2 days. They had their masks on, they had their footies, they're doing investigations. So that was working. But again, it was maybe 3 weeks ago when I asked for follow-ups. Not much has happened since, but there has been movement. So I know that those services are still happening. I can only imagine that they're increasing at this time.
And I see there's a question about OPA introducing an online platform for school districts. The challenge I think we would run into is schools are being just inundated with so many resources. I don't know how we would garner the audience per se to try to get that to where it would need to be. There is certainly a lot of training happening across the educational administrative groups and a lot of guidance. And actually today, curiously enough, now some of the guidance is switching to what happens when schools reopen, which is the first time I've actually seen that guidance come through. So everything has been kind of the reactive. Now schools are closed, what do we do? Now it's like, well, what's going to happen when schools reopen, which is a whole separate probably discussion altogether. There are a number of different resources being put out through the Ohio Department of Education. I certainly would say too, I've spent the last couple of weeks curating a lot of content in Akron Public Schools. If you take a look at Akron Schools and click on the Family Engagement Center, I have a lot of different videos and things on there that you certainly can appropriate into your purposes. The reality is there is not one central clearinghouse, because remember, in education, we have all these different feeds coming in. We have school psychology, we have school counseling, we have the administrative groups, we have the curricular groups. So we have a lot of, voices speaking all at once. And schools are struggling across the board because they have all these voices talking to them, but at the same time, they're also trying to keep curriculum going for such that they can in the next couple weeks. And remember, again, for most schools, this is April 23. So by and large, in the best case scenario, most schools have about a month. Even in my district, the mantra starting this week was 33 days to go. And so everything was about, let's get through 33 days. And there's still no indication what the summer is going to look like, if there's going to be extended school year services, or if anything. And Kim, I see a hand.
Up to 5 minutes.
We got
5-minute warning. Now 4. Yes.
So Kim's giving us the 5-minute warning. So for Keelan and I to be most helpful, what are some maybe parting thoughts or parting questions we can try to answer, or parting resources we can try to yield? And certainly please understand that this is not a one and done. We can gladly come back in a couple days, couple weeks. But we're just trying to offer some immediacy support today. And not all at once.
Mhm. Anything that you guys were hoping for us to cover that we didn't get to?
Or that we didn't maybe give enough coverage to. Again, let me invite, and I see Antoinette has a hand. Is she's either saying okay or okay. I see an okay. Remember again, do check out the National Association of School Psychologists. They have some of the probably best psychologically mediated content that we have in this area. And they have a direct link to the COVID resources. I'll put my email there again. If there's something you need, I will certainly either try to yield it to you. Keelan, do you want to type your email there as well?
Sure.
If you email Keelan and me, or you email one of us, we'll copy both of us in. And if we can't come up with a response or support, we certainly will do our best to try to connect you to something or someone. Keelan, a question here about securely sending forms.
Mm-hmm. So I had a long conversation about this with our online people today, or I guess my website person, and I'm still looking into this. So especially now that everything is over the internet, I want to make sure that we're secure and that everything's HIPAA compliant, because there's an increase. And I was told that I am as secure as the internet is, and as my password is as well. So if I'm sending forms over the internet, if I have a secure password, if I have a secure connection, I'm doing everything I can on my end. I send forms through the internet, blank forms, and I ask them to mail them back by US Post. It's kind of on them. Some people agree, some people don't agree. But then through the testing websites, I don't send anything. It just goes right through the websites. So yeah, it's very confusing. Like I was like secure, encrypted, HIPAA compliant. Are they all the same thing? It's so hard to know. And I'm on that journey just to make sure that we're doing everything right. It seems like we are, but I can't explain it because I don't really have the best understanding.
And then Michael wanted us again to reflect on the fact all of us have been propagating information on the Ohio Psychological Association website. And that has been a just tremendous group effort. Ohio's ohpsych.org, or I put the link in our chat there. There is just an unbelievable wealth of content. Our Director of Professional Affairs, Jim Broyles, Dr. Broyles has just been tenacious, hosting various forums on insurance and billing issues. We've had just a benefit of so many different consultants and collaborators on telepractice issues, State Board of Psychology guidance, OPA related guidance, APA guidance, NASP guidance. So there are lots of different tiers of guidance there. And again, if you just either Google the Ohio Psychological Association or ohpsych.org, right on the main page is a big graphic splash for COVID-19, which will take you into all of that. So certainly do check that out as well, because that's sort of the amalgamation of everything that we've talked about tonight. And then the Ohio Department of Education does have some very specific guidance. I won't send you endless links here, but if you just Google Ohio Department of Education and coronavirus or COVID-19, you will see that they have a number of different pages up related to special education issues, crisis issues. But understand that the state education agencies, or SEAs as we call them, are still languishing because they're really looking for decisive federal guidance, whether or not there's going to be waivers on certain things and so forth. So But there are a number of different resources available there as well. We are 1 minute over our welcome, and I'm sensitive. I don't want Keelan and I to wear out our welcomes. Would this be helpful for us to come back in a week or two and have more conversation or questions? Or are we good? Let us know, because we certainly can do that.
Okay.
All right. Well, Kim, I guess we've reached our stopping point.
Thank you so much for coming, everybody. We appreciate it.
Thank you all.
Thank you for your time and all the knowledge that you've shared.
Okay.
Have a good night.
Good night.
Good night.